You did the right thing. You showed up for your routine checkup, rolled up your sleeve, and followed every instruction. 2 days later, something felt off, dizzy when you stood up, a shimmer over your vision, a heaviness you couldn't explain. Was it just stress? Or did the routine test itself push a fragile system a step too far? After 60, our bodies are more responsive to help and to harm. Most tests are excellent tools when they're used for the right reason, at the right time, in the right person. But a handful of common tests can also nudge blood pressure, stress the heart, or interact with medications in ways few brochures spell out. This isn't about fear. It's about precision and partnership, asking better questions, preparing wisely, and matching the test to your unique risk profile so you get answers without unwanted surprises. In this guide, we'll surface the 5 test categories seniors should approach with informed caution, break down how risk actually happens in plain English, and hand you scripts to use at your next visit. Educational only, not medical advice. Bring these points to your clinician. Your voice matters and it changes care. Let's protect your brain, your heart, and your independence. Core thesis testing saves lives when it's tailored. The hidden problem after 60 isn't too many tests or too few tests. It's misaligned testing. Tests ordered just because, repeated without a clear plan, or performed under conditions that quietly raise risk for vulnerable seniors. The body you live in today has different guardrails than the body you had at 40. Blood vessels are less forgiving of sudden pressure swings. Kidneys may clear contrast agents more slowly. Sedation can drop blood pressure more than expected, especially if you're on blood thinners. None of this means you should avoid care. It means you should steer it. The winning formula is simple, clear indication, plus safest method that still answers the clinical question, plus thoughtful prep and follow-up. Ask, will this result change what we do next? If the answer is fuzzy, you may have time to choose a safer alternative, prepare better, hydration, medication timing, or monitor first. Throughout this piece, you'll find practical US-friendly checklists, plain English mechanisms, and conversation scripts. Bring them to your next appointment. The goal isn't to say no, it's to say yes to the right test at the right dose of risk for the right reason. The 5 tests to treat with informed caution. Let's walk through 5 common test categories many Americans over 60 encounter. Each can be appropriate, even life-saving when indicated. The key is fit, your diagnoses, your medications, your kidneys, your baseline blood pressure, and your recent symptoms. For each, you'll get what can go wrong, who's more vulnerable, and safer ways to get to the same answer. CT scans with iodinated contrast. What can go wrong? The contrast injection helps outline blood vessels and organs, but it can trigger quick, sometimes dramatic shifts in blood pressure. Some people experience a vasovagal dip, heart rate and BP drop, leading to dizziness or fainting. Others see a spike that stresses fragile arteries. If kidney function is reduced, the dye places extra load on clearance. Who's more vulnerable? Adults with poorly controlled hypertension, known cardiovascular disease, chronic kidney disease, CKD, prior contrast reactions, dehydration, or recent illness. Safer path. First ask, do we truly need contrast to answer the question? Many abdominal, chest, and head questions can be addressed by non-contrast CT or ultrasound. If contrast is essential, show recent labs, especially eGFR, hydrate beforehand, unless your clinician restricts fluids, and share any past reactions. Have your home BP log handy, 3 days of AM, PM readings. If your BP is running high, a brief optimization step may lower risk. B. Exercise treadmill stress test, ETT. What can go wrong? The treadmill ramps speed and incline, spiking heart rate and blood pressure. In a healthy 30-year-old, that's a feature. In a 70 or 80-year-old with stiff vessels or arrhythmias, it can tip the system into dangerous territory. Severe BP surges, irregular rhythms, chest pressure, or neurologic symptoms. Who's more vulnerable? Adults with known vascular disease, limited mobility, frailty, poorly controlled BP, or a history of arrhythmias. Safer path. Ask, is there a pharmacologic stress test, medication that simulates exercise, or a resting echocardiogram that would provide the information you need with less hemodynamic stress? If you do exercise test, ensure a gradual protocol, pre-test BP review, and clear stop rules. If I feel dizzy, we stop immediately. Confirm that emergency protocols are in place and that your test is supervised by staff experienced with older adults. C. Sedated endoscopy colonoscopy. What can go wrong? Sedation commonly lowers blood pressure, and in older adults on antiplatelets, aspirin, clopidogrel, or anticoagulants, warfarin DOACs, periprocedural bleeding, and microembolic risks can rise if medications aren't timed correctly. The combination of age-related autonomic changes, fasting, dehydration, and sedation can set up a perfect storm. Who's more vulnerable? Adults 65 plus, anyone on blood thinners, people with autonomic instability, recent TIA, significant anemia, or borderline hydration. Safer path. Clarify indication and urgency. Why now? If it's routine surveillance with no new symptoms, ask whether timing can be adjusted, whether minimal sedation or no sedation options exist, and get a written plan for holding, bridging blood thinners. Confirm a ride home and plan a check-in call the next day. Bring your medication list, drug, dose, time. Rehearse your symptoms vocabulary so you can report dizziness, chest tightness, or vision changes immediately. MRI with gadolinium contrast. What can go wrong? Gadolinium is usually cleared by the kidneys. After 60, eGFR can drift down even if you feel fine. Slower clearance means more exposure time, and in rare cases, gadolinium retention is linked to systemic and neurologic symptoms in susceptible people. Who's more vulnerable? Anyone with CKD, known or undiagnosed, diabetes with kidney involvement, cumulative prior contrast exposure, or recent acute illness that can transiently lower kidney function. Safer path. Ask for non-contrast MRI when diagnostically acceptable. Often it is. If contrast is pivotal, get a same-week eGFR. Discuss the specific gadolinium agent class, some have a more favorable stability profile, and confirm the smallest dose that answers the question. Hydration helps unless you're on fluid restriction. Document any prior odd reactions. I felt unusually foggy for 2 days. That's clinically relevant. Fishing carotid ultrasound in asymptomatic adults. What can go wrong? Carotid ultrasound is painless and fast. The issue isn't the scan, it's the cascade. An incidental 50-60% narrowing can sound alarming, leading to rapid referrals and procedures, stent or endarterectomy, that carry non-zero stroke risk during or after the intervention, even when medication and lifestyle optimization might match or beat procedural benefit for people without symptoms. Who's more vulnerable? The truly asymptomatic adult who is already on good blood pressure and cholesterol management, who then gets steered toward invasive steps with minimal gain. Safer path. Ask, if this shows moderate narrowing, will our plan change beyond optimizing meds and lifestyle? If you're already on a statin, BP control, and a healthy routine, periodic monitoring may be smarter than rushing to surgery. If an intervention is proposed, seek a second opinion from a stroke-focused center and ask for absolute risk numbers, benefit versus procedural risk for your profile. How to decide in real-life indication clarity. Will this result change what we do next? Least risk path. Is there a non-contrast, non-sedation, non-exercise alternative? Your baselines bring eGFR, a 1-week BP log, medication list with times, and allergies. Hydration and fuel. Unless restricted, aim for steady fluids the day before and morning of water, broth. Avoid showing up dehydrated. Stop rules and supervision. Ensure you have permission and encouragement to stop any test the second you feel unwell. Aftercare. Plan a ride, a check-in call, and a calm afternoon post-test. Watch for red flags, one-sided weakness, slurred speech, sudden vision loss, a new worst headache. In the U.S., call 911 immediately. Minutes matter. Bottom line, the right test, done the right way, is an ally. Your questions make it right. How risk actually happens. Think of your circulation like a carefully balanced highway system. After 60 lanes narrow a bit, traffic moves differently, and on-ramps, off-ramps, blood pressure rises and drops are less forgiving. Hemodynamic swings, a sudden spike on a treadmill or a drop with sedation, can strain vessels that have less flexibility. Autonomic triggers, vasovagal responses, can briefly crash heart rate and BP. Proclot conditions, fasting, dehydration, medication holds, make blood stickier, raising the chance of a tiny clot in the wrong place at the wrong time. Renal clearance limits mean contrast dyes may linger longer than expected, extending exposure. And then there's the cascade effect. One incidental finding can tumble into more tests and procedures, each adding a slice of risk. The solution isn't to stop driving, it's to drive smarter. Slow the curves, gentler protocols, check the map, clear indication, tune the engine, meds, hydration, and choose the safest road that still gets you there. Plain English, not panic. This is how you keep risk in its lane. Pre-test safety checklist. Your aim is simple. Only test when it truly helps in the lowest risk way with solid preparation. Use this short, complete checklist in order. Clarify indication and action value. Ask plainly, if this result is normal versus abnormal, how will it change my treatment plan? If the answer is vague, suggest delaying or choosing a lower risk option first. Monitoring, basic tests. Seek lower risk alternatives. Try, could ultrasound, non-contrast CT-MRI, or a resting echocardiogram answer the question? For stress testing, consider pharmacologic stress instead of a treadmill if you have high BP, stiff vessels, or limited mobility. Medication prep, polypharmacy is a hot spot. Bring a typed list with drug name, dose, time taken. Include aspirin, warfarin, DOACs, clopidogrel, diabetes meds. Get a written hold at bridge plan. Dates, times, when to restart. Bring your pill organizer, Hatcher bottles if reconciliation may help. Check kidney function before contrast request a recent eGFR, same week if possible. If eGFR is 60, discuss contrast type dose or whether avoiding contrast is reasonable. Blood pressure, bring the real picture, log AMPM BP for 3 to 7 days, seated, 5-minute rest, 2 readings each time, record the average. If averages are 140/90, ask about tightening control for a few weeks before testing to reduce hemodynamic swings. Hydration and fuel, unless you're on fluid restriction. Practical target, about 64 fellows day. Spread from morning to evening. Water, herbal tea, broth. Don't arrive dehydrated or hypoglycemic. Confirm fasting rules in advance. Prior reactions and allergies. Don't skip the weird details. Report any past reactions. Dizziness, near fainting, hives, trouble breathing, prolonged fatigue after tests, contrast with sedation. Ask for a prominent chart note and preventive steps. Pre-meds, hydration, longer observation. Day of logistics, arrange a ride home if sedation is possible. Block downtime afterward. Request a BP recheck before discharge if you've ever felt off post-test. Your closing line. If the result won't change management, I prefer the safest alternative first. Bring this checklist to the visit. Be brief, specific, and calmly repetitive when needed. That's how you turn testing into a precision tool instead of an avoidable risk. Conversation scripts for your next visit. Treat this like a cue card you bring into the exam room. Keep your tone warm, concise, respectful, but clear about the goal. The right test, lowest reasonable risk, useful for decision making. Nail the indication and action value. You say, given my age and blood pressure history, what's the lowest risk test that still answers your question? Short version. If the result is normal versus abnormal, how would our plan change? Why? Pushes the conversation toward clinical impact, avoids just in case testing that won't change management. Ask for safer alternatives. You say, could we start with ultrasound or non-contrast imaging and only escalate if needed? If it's a stress test, instead of the treadmill, would pharmacologic stress or resting echo give equivalent information? Why? Choose the least risk road that still gets you there. Meds, kidneys, and pre-test prep. You say, I'm on aspirin, warfarin, clopidogrel. Could you give me a specific hold, C-bridge plan, dates, times? If contrast is possible, I'd like to check eGFR first. My last was 58. Does that affect the type and dose of contrast? Why? Lowers bleeding, clotting risk, and kidney exposure through intentional prep. Blood pressure management and stop rules. You say, my home BP averaged 148/86 last week. Should we optimize control for a few weeks before testing? On test day, if I feel dizzy, chest pressure, visual blurring, please stop immediately and recheck my BP. Why? Avoid sudden hemodynamic swings, a common trigger of complications in older adults. Real. Document prior reactions and prevent repeat issues. You say, I've had dizziness, near fainting after contrast before. Please note it in my chart and suggest preventive steps. Hydration, pre-meds, longer observation. Why? Turns past experience into a protective plan. Prevent the slippery slope from incidental findings. You say, if a carotid ultrasound shows moderate stenosis and I'm asymptomatic, would medication plus monitoring be equivalent to intervention for my case? Could you give me the absolute risk numbers? Why? Stops incidental results from cascading into unnecessary procedures. Post-test plan and red flag coaching. You say, after a test with sedation or contrast, I'd like a short observation and a BP recheck before discharge. Please review what symptoms mean 911 within the next 24 to 72 hours. Why ensures aftercare and a safe trip home. When to seek a second opinion, you say, if a vascular procedure is proposed, I'd like a second opinion at a stroke center. Could you summarize my chart and help with the referral? Why? Improves decision quality, reduces system bias. A confident, courteous closer, you say, if the result won't change my plan, I'd prefer the safest alternative first. Why? Affirms your shared decision-making rights while keeping the relationship collaborative. Pro tip, print this cue card and underline your numbers, BP averages, eGFR, meds, dosing times. Be brief, specific, and willing to calmly repeat key points. That's how an engaged patient helps the care team deliver safer, more precise medicine. Who should be extra cautious? You'll benefit most from a precision approach if you recognize yourself here. Uncontrolled hypertension, home BP averaging 140/90, prior TIA or stroke, history of atrial fibrillation or other arrhythmias, heart failure, diabetes with kidney involvement, known CKD, eGFR under 60, anemia, recent dehydration, or illness, frailty, weight loss, weakness, slow gait, or polypharmacy, 5 or more daily meds, especially blood thinners. None of these are stop signs. They're caution flags that call for better prep, gentler protocols, and closer observation. Bring your health snapshot, 1 page with diagnoses, surgeries, allergies, meds with times, last eGFR, latest lipid panel, and a 7-day BP log. If you need help building it, ask your clinic's nurse navigator. Many systems have templates. When your team can see your baselines at a glance, they can right-size testing to fit you. often swapping in a non-contrast scan, a resting study, or a slower treadmill ramp that answers the question without tipping you over. When testing is the right call, balance matters. If you have new chest pain, pressure with exertion, shortness of breath, one-sided weakness, slurred speech, vision loss, a new worst headache, suspected bleeding or clot, infection, or a potential cancer, prompt testing is the safe choice. In emergencies, the benefit of speed dwarfs the incremental risk of contrast or stress. Tell clinicians your concerns. I've had dizziness after contrast. But don't delay urgent care. In non-emergencies, use the questions in Part 7 to aim for the safest path that still produces a decisive answer. Remember, the purpose of every test is actionable clarity, to confirm or rule out a diagnosis, to guide treatment, to keep you home and independent. If the result won't change management, you may have room to prepare better, choose a lower risk method, or monitor. That's good medicine, not avoidance, but precision. Action plan, you can start today. Build a one-page health snapshot, diagnoses, surgeries, allergies, meds with dose and time, last eGFR, 7-day BP averages, emergency contacts. Print one, keep one on your phone. Hydration habit, unless restricted, aim near 64 fel-Oz day, spread from breakfast to evening. Add a pinch of salt or a splash of lemon if it helps you drink. BP routine AM and PM, seated, back supported, feet on the floor, 5 minutes of quiet. Record 2 readings each time, log the average. Scripts on your phone, copy Part 7. Use them verbatim, that's what they're for. Post-test buddy. If sedation or contrast is planned, ask a friend or family member to check on you the next day. Medication timing. Keep a simple weekly grid that shows exactly when you take each med. Bring it to appointments. Confidence phrase. Practice saying, if it won't change my plan, I'd prefer the safest alternative. Calm, firm, respectful. Your care team wants what you want, the right answer with the least risk. You bring the lived-in wisdom of your body. They bring the tools. Together, you'll choose well.